Today we have got something special. We're talking about cooled radiofrequency. For those of you who are familiar with conventional radiofrequency, what we do is we're basically going after a small nerve and we're heating up the tissues around that nerve, which heats up the probe, which causes destruction. Now, typically we're going to about 90 degrees Celsius on these regular radiofrequency. But so why do we do cooled? Well, it's easier. So why do we say easier? Well, what we always want is we want a large lesion, meaning the area of destruction, we want a larger area because it gives us a greater margin of safety. So in that regard, what we're going to look at is, let's look at the probe here. If you look at the probe, on a conventional radiofrequency probe, if this is the active tip, we're only going to get a lesion from about halfway of the active tip and maybe just a little bit beyond. And the reason for that is we get tissue destruction. Once we get tissue destruction, we're not going to get any more lesioning out of that. So the cooled system allows us to generate a longer amount of thermal destruction. But at the same time, by cooling it down to about 60 degrees, we're allowing the lesion to propagate. It's going to propagate away from the tip. So now that means that we have a little more ease in placement as well. So if we look at our spine model here, how would we do a conventional radiofrequency needle placement? Well, we would place it, right along here underneath the ligament called the mammalar accessory ligament, where the medial branch off the posterior primary rami sit. It sits here, and we want to have a thermal lesion right about here. Now with the cool technique, you know what's cool? Forget about trying to angle it. Forget about trying to walk it off or anything else. We're just going to go right down, for example, in the spine, down to Scotty Dog, bump, right to where what we call the eye of the Scotty Dog. Boom, we hit bone and we're there. We don't have to worry about walking it off the bone and everything else. We just boom and hit bone. Another advantage in that is, look at this. Here I have my posterior primary rami. I'm going to stay away from those. I'm not worried about the tip of my needle kind of bink, bink, touching that. I'm not worried about that. I'm going to be right down on the bone. I know that I don't have a posterior primary rami there. I will, of course, do a quick test anyway. However, it gives me just an extra margin of safety. And that's what it's all about, is doing things efficiently, but giving the patient an extra margin of safety. Okay, we're going to look at a couple of these different methods. And what's great about cooled radiofrequency, I can go where I feel like Star Trek, where no man has gone before. For example, we talked about the spine. I can do hip. I can do shoulder, both an anterior and posterior approach for these larger joints where the nerve is much larger. We'll see that in a few minutes when we get our prototypes under the X-ray.